this procedure now, and it's just, Jackie, thank you for your nodding there. Yeah. And it's just a reminder to colleagues that we do, of course, seek to hold this in public as best we can. The compromise at the moment, of course, is that we're an online meeting, but that we record this and do publish the meeting. And so that's the purpose of the recording. Also ensures, of course, an accurate record of what's been discussed and what's been said. And I can see some people just may still be coming into the meeting. So Dermot, thank you. Noted regarding Helen. Hopefully she can get the link. But Lord, I know I always turn to you when there's these sort of things, but perhaps you would just, perhaps you could try and help Helen if she needs it.
Yeah, that's fine. Yeah.
Thank you. Maybe through an email or something. Yeah, thanks very much. Okay. Right, well, good afternoon, everybody, and welcome to our Council of Governors open meeting. I began in introduction there by thanking the governors for their close session and indeed the time that they spent with us as non-exec directors, dealing with a few of the things that came to mind. And just to share again, particularly for exec colleagues that have just joined us, thank you for such a strong attendance from our exec colleagues. I think it works quite well, that, because it allows the governors to think about what matters to them at the moment, what's in their mind, and then they get straight into those kind of points when we're discussing amongst non-exec directors. So we try to, of course, manage things by the nature of academies, but there were a few points raised that I do just want to turn to some exec colleagues, hopefully, and get some assistance or some detail, or indeed a promise to provide detail where it might be helpful. All very productive and supportive questions, entirely appropriate. So we will do that as we begin the meeting. Laura, may I just make a note for you, please? Fahim, so thank you to Pat Campbell and to Fahim, who is joining us, I believe, at 4 o'clock from an HR perspective. And there was an issue, a question raised by governors about the nature of our temporary and fixed term contracts. And the interest from governors was a flavour of how many of those we've got. And the ethos of the question related to employment terms and how it might affect them. So I don't think there was anything hidden in that, but just an idea of the number of contracts that we have that might be temporary or for a fixed term within our organisation. So if Fahim is able to provide that, then terrific, or touch on that. But at least if we just give him a heads up, please, Laura, that there may just be a question about that.
Yes, that's fine. We'll do, Max.
Thank you. I know I'm giving you little jobs to do here, but I would imagine he's probably best placed for that. I think because we're in the different meeting now, Dermot, it's I don't have access to that previous chat, do I? So, and how many people on fixed terms have been so for 2+ years? Yeah. Okay. So something about, and in fact, the question is now posted again in chat, Laura. So it might be just helpful. I realise we're asking for him to immediately provide something if he can, and not the moment it comes in at 4, of course, but we'll find a moment to do that properly. So thank you for that. If we could pass it on, that'd be great. Mel, just for yourself, I know we'll be doing a chief exec update, and I will, of course, start this meeting proper, but I'll get these things done now. Just a heads up to exec colleagues. You were thanked, Mel, by Wendy for your information you helpfully provided regarding Ukrainian refugees and the sort of situation we were in. But would you mind, if possible, would you just maybe touch on that readiness and the methods that we have for dealing with any possible influx of refugees during the course of your update, please? Saj, thank you to you for the previous update you provided to governors regarding the use of the independent sector. The private sector was a really helpful briefing. I think there was just a further point, Saj, about how do we assure ourselves when we're paying these people to help us deal with the backlogs regarding performance. So I think a governor or two may have just had some stories or some personal experience, or perhaps performers that hadn't quite reached what they hoped. And it was just what methods might we have, please, for performance. So thank you for that. Karen and Ray, and I think Ray may be tied up with something to start with. So just, Karen, just so you know, one of the matters of interest to governors was regarding quality improvement. I don't think anybody's got any doubt there's some great work going on with our quality team, but it was, the question was, do we learn from small, what you might call minor incidents, maybe even near misses? So it was just about, like, do we seek to try and learn from all natures of incidents rather than those that are perhaps escalated to a particular high level? Hope it might be okay just to touch on that, please. And Karen, just while I'm with you, appropriately, there was a terrific interest in Ockenden, and I think I could almost reduce the kind of discussion we had to two main points. The non-execs, of course, dealt with the questions very well, but there was a good challenge to us as do we treat the new Ockenden report as if it had happened on us? So do we look at those 15 things and work towards mitigating those if they affected us in this area? So do we treat that report as if it's on us? And there was a question, please, Karen, if possible, about midwife vacancies. And we wondered, we understand it might be something like 7 midwife vacancies at Bradford Teaching Hospital. And the question from governors was, how does that compare perhaps with other trusts? And indeed, are there any issues for us particularly regarding recruitment of midwives? So, Karen, I know you're on the call, and I'm assuming you can hear me okay, but thank you.
Would you like me to take those 3 points now, Chair?
Well, actually, yeah, what I'll do is I'll begin them. I didn't want to go straight in and turn to people and say, tell us this, tell us that. So I was just trying to give a heads up, Karen. But I think I will deal with these things first, because they are the summary from the pre-meeting. So thank you for that. I think I've dealt with all the things. Oh, yeah, there was just the issue about visits to hospitals, Laura and perhaps John. Governor visits. So, Laura, we do appreciate that you wrote to all governors advising them of our hopes for perhaps in June to sort out some presence on hospital sites. But there was, I think, just a little discussion about how we might be wanting to do that. So it may be that we just come for a little more detail as to how we're going to actually allow governors to come back on site and start to experience some of the services that we're providing. So, Laura and John, I'll just say that I don't think there's any issue about that. I think it's just some assurance about is this definitely on its way? On its way. That's great. Okay, there's also the risk issue, isn't there? So I'll come back to that, I promise. That's fine. And David, would you like to come in, please?
Yeah, thanks, Max. So on Ockenden, there was also the question about providing assurance that we listen to parents when something's gone wrong, which was one of the big things that came out of the Ockenden report, I think. Yeah,
very good point.
Yeah, thank you.
No, you're absolutely right. Thank you. Yeah, are we listening? Are we hearing? So we did talk about things like maternity voices and our patient engagement strategies regarding maternity. But again, as ever, it may be that some execs have some additional detail that they might want to share. So yeah, thank you. But I do want to emphasise all the questions are constructive and appropriate, and it's just some detail and assurance hoped for by governors. But it does provide just a little more challenge on us. So that's great. Welcome everybody to the meeting. We do note Anne Forster's apologies. Are there any other apologies that I should note for this meeting, please? Okay, I don't think so. And I think we do have certainly a full complement of...
Just to note, Max, there are Stella's apologies. Stella Hall.
Stella's, thank you very much, yeah. So we'll note Stella's as well. Thank you, Jackie. Yeah, and I think we've more or less got a full complement of directors, haven't we? I know that a couple have got particular things on at the moment. I think Ray advised me that he was going to just be a little bit late. And I'm grateful to Altaf, who is on business away, but I think is with us. In fact, I can see that Altaf is with us as well, so that's great. Thank you. We're asked to note, please, the declarations of interest and to confirm that we are content that they are an accurate reflection of those declarations. And it's my duty as chair, of course, to remind everybody present that should a particular interest arise during the course of the meeting, they ought to declare it. And indeed, it comes slightly to me, doesn't it, as we talk about the appraisal processes later in the meeting. So that affects me as a personal interest there, of course. Okay, we'll deal with the minutes of the meeting held on the 27th of January. Is everybody content that they are a true record of the meeting that we held on the 27th of January? Are there any matters of amendment that might be required, please? No, it would appear not. That's great. And I think I'm just looking for my copy of the actions to save me trying to find it on Teams. But I don't think there were any outstanding actions to be dealt with, were there? They were all shown as having been achieved. Okay, so I'll just check if anybody wants to pull me up on that. I can't find the document that I should have in front of me. In fact, I know where it is. It's right under the agenda. There you go. So, yeah, we've got the 3 actions closed at the bottom, haven't we? And then the summary of the availability of site visits, indeed, for governors to be explored further. So, entirely appropriate question from governors again. As the trust has returned to incident level 4, we're unable to facilitate non-essential visits. It is on hold, though, until the situation improves. And I think, as Laura said earlier, there are some attempts to try and improve on that. Should we use that opportunity then to deal with that issue right away, and perhaps just go to Laura or John, just to perhaps advise governors where we might stand regarding inviting governors on site? Laura or John, is there anything?
I'll pick that one up if I may, Max, but
Please,
Laura
John,
can come in too. Yeah, so I mean, the first thing to say is obviously we recognise that the circumstances over the last couple of years have not been ideal. It makes it that little bit harder to engage when it's not easy to set foot on the site. But I hope everybody understands the reasons why that's been. There was a question from a colleague about perhaps using an impromptu opportunity, attending the hospital as an outpatient, maybe have a look around and so on. And I think we can't at this stage work with that. You know, we have to have a more managed process, but we are aware that there's plans afoot to do something around June as a sort of celebratory event, both to recognise the contribution of governors who are leaving and to welcome on board new governors who are joining. And I've discussed this with Laura and with exec colleagues, and there's no reason why we couldn't do something around that in a managed way to support governors and indeed any non-exec colleagues who haven't yet had the opportunity to have a look around the site. And I think what we would try and do would be, on the one hand, to do a bit of orientation just to get a feel for the facilities, including some very new facilities which have been put up, and at the same time an opportunity just to answer questions about what's going on, because clearly it's about more than just the bricks and mortar. It's about the way services work, and we've got some exciting changes going on. So there's a little apprehension, I suppose, if I'm really honest, about opening up and free for all, but that's not what's being suggested here. I think in a managed way, starting with kind of governor induction and NEDs who need it, we could do something in June that involved a site tour and some discussion of services and what's going on. If we needed to repeat that in the future, we'd be happy to do that. But let's just start with something that we can manage and make it work. It wouldn't be true to say that all visiting, etc., is completely opened up now. You will know that that's not quite how it is, regardless of what it might say in the Daily Mail or whatever. So we are trying to be pragmatic, strike the right balance. We'd love to welcome governors in, but I think we do that as a managed process of induction in June and then take it from there, see how that goes. I hope that's helpful.
Thank you very much, John. It's extremely helpful. So I'll just pause and see whether any governors had any further questions or concerns that you'd want to raise. Clearly, the message has been heard that you'd like to see us being able to get you on site. Kirsch, please do come in.
Yes, just to further ask and for clarification on that, we were just under the impression that NEDs were allowed in and were visiting the hospital, and it was just the governors that were isolated. Is that the case?
Well, I wouldn't use the word isolated. Some of this is for your own protection, but what we did have was, I think, a discreet visit by some non-execs to see some new facilities. Off the top of my head, I can't remember what it was, but I think it was possibly the new same-day emergency care acute facilities, where a small group of NEDs came in to have a look. And to be honest, for us, that was a bit of dipping a toe in the water and trying to do this right. I don't want a them and us where I say, oh, you know, we do this with the NEDs and we do this with the governors, but we did a small scale thing with the NEDs, and we'd be happy to do something for governors in June and for any other NEDs who haven't had the opportunity.
I think that's all we're asking for, John, really, is a chance to do our jobs properly. If we're away from the hospital, we don't know what's going on. And it just seems, I don't know the NEDs aren't treated any different, but it just seems like, you know, if we can get the NEDs in, then why can we not do the same for the governors?
Yeah, I hear the question, and my response would be, we're going to do something in June. There's always a balance to strike here, and you know, in the past, it's probably been very different and much easier. And what we're trying to do now is move back to something like a new normal. But honestly, we're not quite there yet, and it's difficult to get that balance right. But we will try. We promise our best endeavours.
I understand perfectly what we're going through, and I appreciate that, John. It's just the clarification really as to are we going to get back to normal and then when. That just clears, it helps if we know that we've got June, say, for example, we've got an idea to work to. But thank you very much, John.
Okay.
Thank you. No, thanks, John. Thank you, Kirsch. It's entirely appropriate, and I think we hear the message clearly. Governors are not being left behind in this, so that's entirely appropriate. Yeah, thank you, John. Okay, I'll turn. So we're on item 5, and I realise this will take up some of the meeting, but why not? Because these are the things that governors would like to hear from us. Exec colleagues, we're not looking for full detailed briefings, but just maybe any little additional detail that you want to provide in support of points that were probably made by non-exec directors. So shall we turn to Karen first for the questions on Ockenden, Karen? And obviously governors do know about the outstanding maternity services programme, but the 3 things that were sort of particularly raised were, how do we know that we're listening to parents properly? What's the situation regarding staff? And would it be fair, Karen, to say that we received the recent Ockenden reports and we're thinking, okay, if this was on us, what would we do? So that was the 3 kind of things that were raised, but of course, anything else you wish to bring to our attention, Karen, please.
Thanks, Chair. So I think the first question was around learning from incidents in general and whether we look at lower level incidents. So we absolutely do. We look at all incidents across the board. I'll give a very quick example. In complaints, so we look at complaints, we look at trends. We've noticed some low level incidents in relation to patients' property. Obviously, very consequential to the families involved, but wouldn't be classed as major incidents on the scale of things. And we've actually pulled together some actions around that to look at that. So that's because of lots of little incidents about patients' property either not being treated respectfully, soiled clothes being put in a bag, or something going missing, that type of thing. So we do that across the board. From an Ockenden point of view, so I mean, it's harrowing reading. And so if we go back in time slightly, one of the asks of the Trust is that Trust should look at and review how they have implemented Ockenden 1. So there were 7 immediate actions within that. Which we gave an update. So I can't remember, I think David might have been at board in March, but there was an update given at March board on that, where we were against all of those. And within that is about how we learn from incidents, how we know that we are safe, a safe service. That includes having the right workforce as well. So from a workforce point of view, we look across the board. So we look at the consultant workforce, the junior doctor workforce, and of course the midwifery workforce. To maintain safe staffing, and we know what that number is because it is based on our number of births and something called birth rate plus, which is a sausage machine that you put your births into, the complexity of, and it tells you how many midwives you need. We know that at the moment we've got a gap of about 7. Again, the midwifery workforce is over 200 people. So that is a very small vacancy rate. And we know that we will recruit to those very easily come September. So from a vacancy point of view, how do we compare with others? Very well. So we've always been able to recruit in Bradford, and we're hoping with the success of Yorkshire Midwives on Call that we're going to get inundated with people wanting to work in Bradford now. So if anybody wants to know how our midwives handle risk, if you've not seen the Yorkshire Midwives on Call on BBC, on iPlayer, please do so, because what that will show, you will see midwives interacting with our women on a very personal level, building relationships, but also managing risk, the risk of the woman, the risk of the baby, and doing it exceptionally well. So I think that's a great sort of window of maternity care. In addition to that, you asked about do we listen to women? So we work very closely with something called Maternity Voices Partnership. We've done a lot of proactive work with those, including 15-step reviews where people walk through the unit and make changes to the unit. And we've certainly listened to a lot of women around that. What we probably don't always get right, but we are trying to improve, but it's very difficult, is how do we listen to people when things don't go to plan or things go wrong? So we have something called the PMRT, which is where we review any adverse incidents like a stillborn baby or a neonatal death or a baby that suffers some brain damage at birth. Within that, we are mandated because of that to speak to families and gain their views, and we do that in those cases. It has been fed back recently that we've not always captured the families' views as well as we could do. So we're really making sure by looking at additional specialist posts to enable us to really home in on that woman's voice, especially when things go wrong. But the other important thing to do is to pick up on that woman's voice when things go right as well. Because even if somebody's had a good experience and a good outcome, there might be things that we could have done even better. But I would say that midwives are quite forward, not backwards in coming forwards. The work that we've done around the Outstanding Maternity Programme has stood us in good stead. So when we submitted our Ockenden submission to the region, the feedback we got was that it was one of the most comprehensive submissions that they'd seen. And we were progressing very well against those actions. I think that covers everything, Chair.
No, that's great. And of course, I'll pause and just see whether the governors wish to pick up on anything you might have said. That was really helpful, thank you, and got to the point. Karen, may I just throw one last one at you, please, which was, it was a really good point raised, actually, by a governor about risk. And it was, they were delighted to see the risk management strategy and the work that's being done, and Barry articulated that very strongly in terms of the audit committee's role. But the question raised was, how do we know that all risks are being raised? So I talked about exec to CVU meetings, and but the question fairly posed, I don't think there was a suggestion it wasn't happening particularly, but the question was raised was, how are we assured that people feel confident in raising potential risks and that they are then recorded as such? Is that okay?
Yeah. So I'll start with saying, so am I 100% assured that 100% of risks are raised? Well, no, because you never know what you don't know. But what we do have is systems in place and training throughout the organisation about risk and how to manage risk. And risk it starts at a ward or departmental level or an office level. And people know to do risk assessments and to escalate risk and to score risk. And we also have our incident management system as well, which also picks up risks and would also lead us back through a feedback loop. We know then that there are probably thousands of risks on the risk registers across the trust. So if you think a department might have 10 risks on it, you multiply that by 100 departments, you're getting into big numbers. Those are then polled and looked at ward and department level, CBU level, care group level, or a corporate department level. And risks that score 15 and above, we also then look at as an executive, and we link with the named risk holder on those to make sure that those risks are being managed appropriately and the risk assessments are in place. So we do manage a lot of risk because a lot of our business is managing risk. I'm assured that there are systems and processes in place. We know they work, we've seen them work, but I don't think I could honestly say that every single risk is picked up.
Thanks very much, Karen. That's clear. So we've talked about learning from incidents in terms of quality improvement. We've talked about risk and encouraging risk reporting and risk recording in order we can mitigate it properly. We think we're getting much better at that. And we talked in detail about matters arising from Ockenden and received assurances from Karen about us being on it in terms of that latest report. So I'll just ask whether our quality academy leads, Mohammed or Janet, would wish to add to anything that's been said. And if not, I'll open for any further questions or comments. So Mohammed or Janet, was there anything further you would want to add to the points that have been made?
I wasn't going to add. I don't. Mohammed is with us. Karen summarised the points, particularly around the Ockenden questions and risk, and what we only know what we know, which is what I was trying to say earlier, but Karen did it much more eloquently.
This is the point Karen repeated, actually, isn't it, Janet? Yeah. No, that's great. Thank you very much. Yes. And okay. So, and we just have Alistair's point in chat, Karen. Do we capture and act on the family view that they feel something may have gone wrong before it's obviously acute? A major Shrewsbury concern was being fobbed off. Also the question around the 15 IEAs. Have we examined each and assessed if we need to take action on each of those? I know this was done with the January report. So, yeah, so thank you.
The immediate actions are broken down into many sub-actions, not all of which are within our hands. So in particular, there's one that's reliant on additional networks being set out. So they're not all actions for trust. Some of them are actions for NHS E&I, for regions, etc. So around listening to them, so as soon as somebody would raise a concern, we would act on it. But midwives are trained to speak to women throughout the pregnancy to get an understanding of whether they're happy with the care, what's going on, if everything feels okay. And we know that that is something that has absolutely been improved on, because we know that more women attend our maternity assessment centre now because they feel able to raise concerns or concerns about the well-being of the baby and then come into hospital. So we definitely have a culture of listening to women, and I'm confident that we are listening and acting on the views of women.
That's an ethos we promote then, Karen. Yeah. Thank you. Okay, so I'll pause for a second to see whether anything further arose there for governors regarding those points. I appreciate this is taking time up in the meeting, but that's okay. This is current issues that governors are raising, so it's good. Yeah, Karen, thank you very much for the detail you provided there. That was helpful. Saj, may I turn to you, please? And thank you for your previous briefing about use of the independent sector. And I don't think anybody particularly disagrees with the need to use that to help us. But the question was just raised about performance management in those sort of subcontracted areas, if you like. How do we assure ourselves regarding the quality of service that's being provided?
Yeah, thanks, Max. So within the contracts that we agree, they all go through the NHS framework, and within that there are requirements for the subcontracted providers to meet both quality, performance and financial targets, and we monitor that. So we get a report which outlines the amount of work, activity that the private providers have been able to do for us, and that's why within the response that I provided, I was able to tell you how many patients have been seen and where. So that's the first thing. The second thing is that we do also, if we do receive any complaints, we will look at where the patient's care was being delivered. And in fact, we have got example of the not too distant past where we have acted upon those complaints if they've come in and against a private provider and gone and undertaken assurance visits, and indeed, if needed, cancelled the contract as well. So we've got practical examples of where of how we've done that and where we've done that as well. But it is all subject to the fact that we put in a contract agreement with the providers at the outset, through which we can monitor them on an ongoing basis.
Thank you very much, Saj. Thank you. And although, of course, we wouldn't want to mention names at this place, Saj, I'm familiar with a case study in which we stopped contracting with a particular diagnostics provider who weren't providing the quality that we would have wanted. Yeah. Thank you. Saj, thank you very much indeed. Yeah. Okay. And I'll assume that that's dealt with that issue, please. That's okay. And I know Mel will pick up on the issue regarding our preparation in case of refugees arriving in this wonderful city of ours that welcomes that. Julie, would you have wished as Performance Academy Chair to have added anything to that issue of performance measurement and monitoring in independent sector?
No, I mean, we see the high level at F&P, but Saj has got much more detailed knowledge than I have and the Academy has, so that's great. Thank you. Thanks very much.
So shall I pause a second and see whether were there any gaps there, Governors, in our attempts to answer your questions in as much detail as possible immediately upon receipt of the questions? David, does anything come to mind, do you think, that you would have wished to add? And I will come to Wendy. Yeah.
No, nothing further from me, but so Wendy's got a question there.
Yeah, that's great. Thank you. Yeah, Wendy, would you like to come in, please?
Yeah, it's probably not a question, and it's a bit. I think what I have experienced in my family is where a private contractor has not been treating patients the same as their normal patients, like their private patients, and an operation was brought forward, and the person on the phone from the private contractor said, "We've been told we've got to treat NHS patients the same as our private patients." And my alarm bells rang to say, well, maybe, you know, clearly they weren't, and they were, but, you know, I think your monitoring and your contract compliance hopefully has been chasing that one up. But I was just wondering if there were other places that maybe, you know, trust patients were getting, you know, fitted in when it was convenient, as opposed to being treated, you know, dealt with expeditiously.
Thank you. No, that's entirely appropriate, Wendy. And of course, that's ongoing intelligence that we welcome anyway. So thank you. Yeah. Saj, would you like to come back, please? Yeah.
Thank you. And I suppose even before the pandemic, obviously through the Choose and Book agenda, patients are able to choose to receive NHS treatment through private providers, whilst at the same time private providers provide care for patients either through for patients who have got private insurance or who fee pay themselves. You will find that through those private providers that they will have segregated areas or space for fee pay patients themselves versus NHS pay. But overall, the consultant provision is largely through NHS workforce. So certainly the consultants tend to be NHS employed consultants. So I think even before the pandemic, Wendy, that system which allowed NHS patients into the private providers was in place and existed. And like I say, our checks are for those subcontracts and contracts that we have direct with the private providers.
Yeah, no, I do appreciate that, and I think now my experience is it's working. Your contract compliance. So.
No, that's great. Thank you, Wendy, and thank you, Sarge. Yeah, and thanks everybody, because I think to pick up on, I think there were 9 or 10 major issues there, and we've done our best to answer those immediately. If anything's outstanding, it's always okay, of course, to come back to the governance team and say, can I just check this or that, or if there's a little more detail, no problem at all. But that's great, because this is current stuff, and that's what we want to do. So thank you, everybody. Thank you. Okay, we'll move on to item 6, which is the matters raised with governors by members, patients and the public. Laura has helpfully briefed me previously that there was nothing had been raised through that particular route directly with the corporate governance team. But again, of course, I'll just pause and make sure that no governors wish to raise anything that might have been raised with them. In the absence of those, that's fine. We can get on with it and deal with what we've got on the agenda today. Okay, thank you. And we're at item 7 then, which is the chairman's report. Hopefully, governor colleagues have had the chance to read that, have a look at it. Obviously, as always, it focuses mostly on matters of interest to working alongside governors. So there was only 2. I'm going to ask you to take it as read, please, but of course I'll take any questions. But I was only going to raise 2 matters really to emphasise. The first of those is how grateful I am to exec and senior colleagues for their time with governors on the quality account session. So the understanding of QI and priorities in quality improvement, and indeed to so the quality team there, thank you very much, and indeed to Matthew and Sarge for the operational planning briefing that was provided to governors, and the opportunity for governors to contribute to that and to steer our thinking that way. So that was the first of 2 things I was going to emphasise. The second is, and I appreciate it's not necessarily written down in the report because sometimes it's like immediacy of things, but I do want to assure you all that I continue with Mel and others, of course, to represent the trust at a partnership level, both at the well, nationally at West Yorkshire and Harrogate, and of course in the Bradford place, which has just started now, meeting as a board in shadow form, and in fact I will be chairing that next meeting that takes place in June. A couple of quick things to advise governors is some of you will know how passionate I've been about keeping governors well engaged and cited on partnership developments. And the nice piece of news to share with you there is that on the event on the 18th of May, I appreciate governors may have seen this already, we've secured a place for the lead governors of each of our 3 foundation trusts in Bradford. So there will be a Bradford placed event, and that will be really insightful, I think. So it'd be really interesting. It's kind of a get together, and it's almost for the first time as we get into doing things properly and there's a statutory partnership forthcoming. So there's a May event, and I'm delighted to tell you that there will be at least 1 governor from each trust present at that, and therefore able to get the insight into that. And just the last thing I would mention to you on local partnership stuff. So we had our first shadow board. I hope I'm not stealing any of Mel's thunder. She'll talk to us, I'm sure, about our partnership work. But we talked about our strategy for the partnership, which is very similar to our own in terms of people and partnerships and place. But there's a bit of what I thought was good news in that the Bradford Partnership intend to have a spotlight area, and that spotlight area will be children and young people. So we intend, not at the exclusion of anything else, of course, but we intend to focus on how well we are doing with our services to children and young people as a spotlight area. And I think what that will mean is that we'll expect to see detail in relation to programmes of how it might affect children and young people, and we'll be expecting to ask ourselves questions about how might this affect children and young people in our area. So come on, we're the youngest city in Europe, are we not? Do we not want to develop our young people strongly and with a bent towards health and them thinking about their own health and well-being? And indeed, the partnership will be focused on children and young people. As I say, let me make that clear, that's not to exclusion of anything else, but it does mean we will be asking ourselves those things. So I think that's a bit of good news. That's the Chairman's report. If there are any questions, I'm happy to take them. Otherwise, I will propose to move to Mel and give Mel the free text opportunity to ask anything of us. So Mark, noticed that you're with us. Thank you very much indeed. Karen, thank you for your point about freedom to speak up, Guardians, in the chat. And I can see, I think, did I see a hand up? Perhaps not now, but I'm here all day. Oh, David, yes, please do come in. Yeah.
Yeah, thanks, Max. Can you just give us a bit of a brief update on where governors sit in the partnership governance structure? I know you've had discussions on that, so.
Yeah. So, yeah, I think as I mentioned to you in January, I made actually inquiries of the national team as to what are we thinking about the role of governors for ICS development. And that went down very well, because to succinctly summarise the reply I got was, we hadn't really thought about it, Max, and it's about time we did. So it was a really interesting response. And to answer David's point directly, there is, of course, a continuum, isn't there, from, well, governors have a role with the trust, and they'll focus on the trust, and they'll be cited on decision making at the trust, and things will still have to come back to board. We can't go into partnership events and decision making forums, make decisions and not consider them at board. So there will still be site there, right through to, well, shouldn't governors have a say on how an ICS, a local place-based integrated care system, might develop, and what's important, etc., etc. I have to be honest with you, David, and say that that's not settled. And David, I know you're asking on behalf of all governors, so it's not entirely settled yet. But what's pleasing is there is no question that those charged with governance issues of our place-based partnership do know the statutory role of governors in relation to our foundation trusts and the importance of hearing from governors, representation of the people, representation of staff, and of course calling boards to account for how we're making decisions. So they are fully aware of that. My understanding is, I hope I'm not speaking out of turn, but my understanding is as well that committee meetings of the place-based partnership will be open to the possibility of governor observation. So it may be that that's going to be extended beyond governors in order to be fair to all partners throughout the system. But there is an intention to try and make those transparent. And certainly the board meetings, when we become statutory governors, will be public meetings. And so there is an opportunity to see those things. So not entirely settled and articulated yet, David, but I genuinely believe a very positive response from all those senior leaders who are creating the partnership, and that there will be good insight and good engagement with governors. Thank you. I know I can't fully answer that just yet, but I can promise you that it's seriously under consideration, and in the right way, the role of the governors. So there is a citizens panel, which is going to be chaired by or facilitated by Helen Rushworth from Health Watch. So some of you governors may already know our local Health Watch, Helen Rushworth. She's great. And indeed, one of the things she said was that she would be focusing on children and young people's perspectives as well, so that she could address the spotlight area. But she's aware as well of the potential for governor links there and governor engagement. So in fact, I'll arrange for Helen to chat to us perhaps about the role of that citizens panel. That'd be a good idea. Okay. If there's anything further for me, happy to take it. But otherwise, shall we pass to Mel now, give her the freedom of the mic and the ability to bring us up to date with what you think we should be aware of, Mel. So Mike's with you, please.
Thank you, Chair. Okay, so a number of things I'd quite like to trot through and then of course open up to any questions. So as you would be surprised if I didn't, I will start with the COVID situation, because I think that's clearly been at the forefront of our minds for many months now, and to not continue in that vein really, I think kind of endorses a position which we in the NHS are quite keen to assuage people of, which is COVID has gone and it's nothing to worry about anymore. Well, it clearly hasn't gone, because we still have 50 patients with COVID in our inpatient bed base, and that's still a significant number of patients who are still presenting with COVID, even though what brought them into hospital may have been something else. And whilst we cautiously begin adapting to the national steer on the reduction of all the measures that previously pertained to dealing with and containing the pandemic, we do so, as I have alluded to, cautiously, because it is the case that this is still a very transmissible virus, and one that has far-reaching consequences even now for those patients who are vulnerable, extremely clinically vulnerable, or not vaccinated. So it's still a very serious disease with serious consequences, and we remain in a national, interestingly, a national incident level 4 still. However, some of the testing and isolating regimes are being recalibrated, and along with that, we continue to review all our aspects of infection control processes, which includes visiting, to try and facilitate a more flexible regime whilst protecting our staff and our patients. At the same time, we are continuing on our efforts to reduce the backlog of patients requiring elective care. So our elective programme, as the number of COVID inpatients reduced, starts to increase as we get the bed base back into those wards which we can clearly designate as surgical elective areas. And we've continued to do that over the last couple of months, with a focus on eradicating those patients who have now waited 2 years or more for their elective procedures, and the deadline by which we are expected to do that is the end of June. Urgent care demand continues to be unusual for this time of year, so attendance levels in line with probably some of our worst winters over the years. You know, many days where the number of patients attending accident and emergency is in excess of 430, 450 patients. And it's only in the last week or so that that number has reduced back to sub 400 levels. In line with that, actually, the CQC, who have restarted their inspection regimes, have visited us, not because they have come to Bradford Teaching Hospital to assess us as a standalone organisation, but as part of the West Yorkshire system in the provision of urgent and emergency care. And last Wednesday, we were given notification that as part of that system look at urgent care provision, they would be conducting an inspection in our A&E department, which they did. We received some informal feedback on Wednesday evening, and have subsequently received a formal report from them, which basically clarifies the position that we were given verbally on Wednesday evening. So there are some areas that we need to pay specific attention to in relation to our care of patients with sepsis, and some of the documentation of the care that is being delivered in our A&E department. But I have to say, overall, the feedback was very positive about the organisation of the department, the morale in the department, despite it being incredibly busy, the way that they observed care being delivered in a compassionate and very well organised and effective manner. And even one of our pressure points, actually, which is our delays in ambulance handovers, that's receiving patients from emergency ambulances, was observed to be very effective and working very well, which was all good to hear, and we were able to share that with our staff, as well as putting plans in place to address some of the other areas. The report will not be published as such yet, because there are a number of other organisations within West Yorkshire that have to be inspected as part of that, and indeed not just in other parts of West Yorkshire. There are other organisations which I think across Bradford will also be inspected. So a particular focus, for example, on the acute mental health pathway, as that relates to patients presenting in A&E departments with acute mental health problems, which we are aware of, and I have reported previously through this meeting, has been an increasing area of demand throughout COVID and yet still. Our capital programme is drawing to a close for the year 21-22, so a massive capital programme. Many of the things that we have shared with the council over the last year, but most notably theatre ventilation issues, Ward 10 being equipped and refurbished as a surge ITU, our surgical same-day emergency care unit on Ward 2 and 5, the accident and emergency department and its enhanced infection control facilities and the cubicles that have been put in there. And the last piece of that particular jigsaw is the maternity unit theatres. I've been in there today, I've had a look around, I've been filming for the weekly roundup, so if you see that tomorrow, you will see inside some of the theatres and hear from some of our estate staff about what has happened to put those theatres in place that look really fantastic and be a real asset, and all linked, of course, to the CQC action plan from our last inspection in maternity, the Ockenden review, which you've already spoken about, and a key part of our overarching outstanding maternity services programme. That all hopes to come to be operationalised towards the end of June. Staff are just in there putting equipment in and familiarising themselves with that environment, and it will be a real boon to the whole service, a much better, more pleasant and safer environment for our women and their babies. Our operational plans for the coming year have been submitted. They were submitted on Friday. I'm sure Saj has shared with you some of the aspirations and expectations within that, and alongside that, the financial plans, which of course this year, because of the change in funding, different to the way in which we have been operating for the last 2 years under COVID, but a return to more normal funding arrangements with which we are all familiar, which includes the requirement to increase our productivity and efficiency through cost improvement programmes, and one of those will, for the first time in 2 years, be required for the year 21-22, where we'll be looking to CBUs to identify ways in which they can reduce waste whilst not impacting on clinical care, but reducing cost. The financial year draws to a close, our finance team have been very busy in closing the accounts. And just something in relation to the operational plan, which also relates to a major capital scheme that, if we're successful in our bid, we will take forward, is a potential elective surgical centre on the St Luke's site, which would see 2 theatres and day surgery facilities being established there in order to help us address our backlog of patients requiring surgical operations and procedures. That scheme is at a cost of £15 million, just under £15 million, and has been submitted for consideration by the region as part of a targeted investment fund to try and bring down waiting times for patients. If we get the go-ahead of that, we'll be starting to mobilise those plans, which will probably take us into 2 financial years, with the unit not becoming operational until 22-23 financial year. On a place level, Chairman's already alluded to the fact that our shadow board has met for the first time, and that was chaired by Andrew Gold. The next meeting is planned and Max will chair that, and that's because hitherto we've not been able to identify an independent chair. We went through a recruitment process which was unsuccessful. We have started that recruitment process again. This time round we've put quite a lot more effort into reaching out to people who might be interested, and holding just this week we've held an informal information sharing session for prospective candidates for that. The closing date is tomorrow, and we're expecting probably a field of about between 6 and 8 people potentially putting forward applications to be the independent chair, and there'll be a recruitment process thereafter, which will include a stakeholder event. I know Max was involved in the previous one of those that ultimately we didn't appoint through, but that will be repeated. And I just picked up on social media actually that the Health and Care Bill, which is why we're doing this, has just received royal assent and has now become law. That will happen in line with the timescales expected on the 1st of July. And then in closing, just on the point about readiness for refugees, we continue to meet, as we have for the last couple of years actually, as place leaders. And so any intelligence that we pick up about the number of refugees we might have applying to come to Bradford, which is not a process that is being overseen by the local authority. This is the way that the government is handling this is not in the way that we have dealt with asylum seekers and refugees previously. It's incumbent on those refugees wishing to come to the UK to make contact with families who are willing to host them. And it's at that point really that we become aware of their intention to come, and then the process by which they seek and have visas approved will take some time. So we do not have a large contingent of Ukrainian refugees at present. We're monitoring the situation in regards to those that are expressing an interest and applying for visas to come into our patch, and we will endeavour as a collaborative leadership group, providers of healthcare and social care, to work with the hosts of those families to enable them to access primary medical care, secondary medical care as and when they need that. Conscious, of course, that in and amongst anyone who comes from the Ukraine fleeing that particular conflict, there may be women who are pregnant and require our immediate post-antenatal care, and of course children as well, who will be undoubtedly affected by their flight from the Ukraine and things that they have seen and experienced there. And so it's a watching brief that we are keeping in regard to that, Chair.
Thank you very much indeed, Mel. That's really helpful. Thank you for the detail. Mel, just so you're aware, at the earlier meeting as well, Julie helpfully emphasised the importance of the elected backlog and the work we're doing to try and achieve that and get our waiting list numbers down. But I should, as a matter of courtesy, I suppose, just ask whether there's anything on the operational challenge that you would wish to bring to Governor's attention, particularly.
Myself, I think we all appreciate that, you know, the expectation that we have 104-week waits eradicated by the end of June remains a challenging one, most especially because a lot of it is dependent on the availability of certain surgeons. And that's always a dilemma when you're kind of working with a very small margin of error, and you don't have necessarily alternatives to offer some of these patients. If a surgeon goes off sick, or if there is another issue that precludes them from being available to operate, and that does present us with a problem. But what we're trying to do as part of the Wyatt Collaborative is work in a mutual aid way. So between us, we've pretty much committed that we will eradicate 104-week wait patients by the deadline, and if that necessitates offering alternative venues for patients to undertake their treatment, then that's what we do. And in fact, that has happened over the last few months. Indeed, in quarter 4 of this last financial year, 220 patients were treated in a trust other than their host trusts to expedite their treatment. They were offered that choice. Some of them refused, but those that wanted their procedure rather than waiting any longer took up that offer and have had their treatment concluded.
Yeah, no, that's great, Mel. Thank you. It was just whether there was anything in particular you wanted to raise about that operational challenge. We did brief pretty well on that in the earlier session, so thank you very much. Yes, and you make the point there, don't you, about our best efforts to get 2-year waits down to 0. Yeah, thank you. Wendy, would you like to come in, please?
Thank you, Mel. For the Ukrainian thing was my issue, and I was really concerned about it being looked at a place level. I'm involved with Ilkley and the surrounding villages, supporting hosts, and as we speak, I know of at least 20 Ukrainian refugees, and I'm getting emails in from hosts all the time saying I'm picking mine up from the airport. So it is actually happening now, and I think it'll take a little while to start hitting the health scene. But we're very aware that, well, you know, some people are going to have mental health issues, issues about counselling, post-traumatic stress, etc., and just hope that the care trust or the primary care services are sort of geared up to be able to respond to the needs that are, I think, definitely going to be coming their way.
Yeah.
Thank you. Thanks. That is noted, Wendy. Thank you. Thank you for what you're doing there. Yes. Alistair, would you like to come in, please?
Yeah, I just had a very short question around the initiative to work on backlogs by setting up a new surgery site in St Luke's, surgical site in St Luke's. I presume pressures are created for backlogs both due to infrastructure and staffing needs. Obviously, in St Luke's, you've got an infrastructure solution.
Yeah.
Do you know you will have the staffing solution as well?
We know that the staffing solution is going to be probably the greatest rate limiting factor. So we know that we've got maybe 12 months to try and recruit the additional colleagues that we will need. And we'll be planning to try and do that, and to effectively, as much as we can, work with education providers, Alistair, and try and grow our own and develop our own pipeline of people who could undertake the work that's required.
Yeah, and just to widen that question slightly, if I may, Max, because we talked about staffing of maternity services earlier, and I'm sure nursing as a whole has its own challenges. So I know obviously you're working with the university on creating some sort of pipeline for the people we train to want to work with you, and obviously they do placements with you and stuff. But I just wondered, is there is there anything that can be done in the NHS sector that makes us more attractive than another trust? I know you're not free to, give away gold watches or something, but are there any form of inducements that will give people a warm feeling that they want to come without it being outrageous and costly and so on?
Thanks, Hans. Karen would like to come in on that, Mel. Shall I let Karen begin there?
Yeah.
Please, Karen.
All right, so from a nursing and midwifery point of view, we're trying to do many things. So one I've already mentioned, the Yorkshire Midwives, but that has been a real morale boost. People expressing wishes to become midwives and dedicate their lives to Bradford. But we're not just going to rely on that, because we need nurses as well as midwives and other professions. So we're working with a company called Just R, who we've worked with in the past, and they've done a number of recruitment videos, photographs, case studies, which are going live on different social media platforms. They also have algorithms that go behind that push out the reach even further than if just you or I put it on social media. So that's one of the routes that we are taking. We're also about to launch our nursing strategy on Nurses Day in May. And part of that is actually our nursing and midwifery strategy and our AHP strategy. And part of that is about recruitment, retention and recognition. So it's not necessarily a financial package, because we're tied into Agenda for Change. But actually what we can make sure is that we're the best place to learn, the best place to develop people, and that we will invest time to make you be the best that you can. And that is one of our strategies really going forward.
Yeah, that sounds great. I mean, that's exactly the sort of thing I had in my head. Yeah, that's great.
Thank you. Thanks. And Alison, great that you raise it, because of course we've got the likes of Karen Walker here as Chair of People Academy. I'm sure we'll take an interest in those sort of initiatives. So yeah, that's great. Thank you very much indeed. Mel, was there anything further you wanted to add to that, please?
Just to say, I mean, I would endorse what Karen said. The biggest pull, the biggest incentive or investment that we can rely on is the word of mouth of colleagues saying it's great here. I feel looked after, I feel valued, I feel respected. They don't necessarily pay me anymore because it's a nationally set thing, but the benefits are you get support, you get education, training, you listen to, etc. So some of that. The other thing I would say is, and I'm sure Alice, you're aware of this as a place, the work we're reconfiguring in line with the the enactment of the new health bill. A number of new work streams with new focus, not necessarily new because we've already got a workforce one, but we've got a new people committee now, and the joint SROs of the people committee for Bradford District and Craven and Place are Karen Stansfield and a guy called Daniel Hartley, who is the HR director at Region, North Eastern Yorkshire Region. So between them, they are going to lead our response to how do we make Bradford District and Craven, not just BTHFT, the most attractive employer opportunity in West Yorkshire. And I really look forward to working with Karen from the university in that particular role to really kind of think of new and innovative ways in which we can secure a pipeline of future practitioners.
Thank you.
Right, thanks. It all sounds really good.
Yeah,
and I'm sure Karen will be great.
Thanks. And Karen, note your point in chat as well about people coming back as well. So yeah, thank you for that, and thank you, Mel. Just a pause again. If there's any other questions of Mel, really useful Chief Executive Officer update. Thank you. And again, as Mel does, covering immediacy of what we're dealing with and the wider picture as well. So thank you very much indeed for that, Mel. Yeah. Okay, so let's think about inpatients now and how they perceive our services and the survey that's been undertaken. Just before we go to that, shall I pick up on the point that we hoped Fahim might be able to help us on? Fahim, it's not a test, and of course, if you don't quite have that detail at the moment, I understand. But I'm hoping that you had a heads up as to the question from governors about staff on temporary or fixed term contracts, and perhaps if we have, how many of those have been here for 2+ years, etc. So I'm hoping you might have seen the chat comment, and Fahim, do you have any information for us at the moment for that, please? And of course, if not, you can always provide that, we can share with governors later.
Yeah, apologies, Max. I wasn't able to pick you up. I've come straight from another meeting, but I can certainly get that data, and I can make sure it's cascade, well, sent through to you for cascade to governors so that you have that detail. But I will certainly get that data sent across.
That's great. That's great. No, so in the next few days we'll produce a brief regarding that. Will we? I hadn't known that actually, Fahim. So thank you for letting me know anyway. Dermot, did you want to place any context around that might just help Fahim in the preparation of his response?
Yeah, as I said in the previous meeting, was that you know, anecdotally, I know of some people who have had who have been with the trust for more than 2 years on fixed term or short term contracts that keep getting renewed. Sometimes funding pots are such that they can't be relied on. But if someone, of course, has been with an employer for more than 2 years, they have full employment rights. And so that leads us to believe that what point is served by one, making that person having an insecure employment status, or at least it feels insecure, even if it's actually legally protected, and also the hassle for line managers and HR and having to constantly renew contracts. So we're not doing ourselves any favours, and we're certainly not doing the staff any favours if that, you know, if people have been there for a long period of time. So that's really where it's coming from, and I wanted to get a sense of, you know, where we are. You know, we just shouldn't be doing that. If we want to be a good employer, we shouldn't be having. We need the flex of short-term contracts and fixed term where appropriate. But if you've got people who are staying more than 2 years, they're obviously good enough from their job. So we ought to be looking at making sure they have more secure employment for everyone's benefit.
Thank you, Dermot. Thanks. Fahim, is that okay? Would you be able to address those points in a short and brief?
Yes, absolutely. So I think I would like to provide some assurance that actually where we do have fixed term contracts, they are for specific reasons. So I agree completely. You know, where you've got a role that's actually a substantive role, you need that role on a continuous basis. Absolutely, we shouldn't be having people in fixed term contracts. So where we do have people in fixed term contracts, it would be where if we were backfilling, for example. So if someone's gone on maternity leave and we're backfilling, then it's a fixed term contract because we're keeping that job open for the actual substantive post holder, or sometimes, you know, career breaks and sort of some of those absences, or if someone's off sick, long-term sick, we do similar sort of arrangements. And then there will be the funding related ones where actually we might have specific funding for a project and we therefore recruit based on that. But where we can, we absolutely you know, do and should be trying to retain staff. You know, it's a really difficult market from a recruitment perspective, not just in the NHS, but I think across the country, but certainly I think, you know, all across the NHS, we are finding it difficult to fill roles and posts. So fully agree with you on that, I think. But I will get you the figures, and hopefully that'll give you some assurance as well.
Great, thank you.
Thank you. Yeah, thank you, Dermot. Thank you, Fahim, for your assistance there. And I'll make sure that that's shared with everybody who's attending Council of Governors, so they can see that that data. Help us in the thinking. So yeah, thank you, Dermot, for that. Karen, should I turn to you then, please? And we need to think about our inpatient survey and what people are thinking of our service provided, please. If you're speaking, Karen, you're still on mute, so.
That's not like me, is it? So it says 2020, it should say 2021 there, so I do apologise for that. But next slide, please, Jackie. So the survey ran from January 21 to May 21, and it was surrounding patients discharged in November 2020. So some context, and this is relevant, and it's in the final slide actually. In November 2020, nationally, we weren't in a wave of COVID. So the first wave had happened and the second wave hadn't started. However, in the northwest of England and West Yorkshire, we were very much at the peak of our second wave and had round about 175 COVID inpatients at that time. In addition, we weren't doing any elective planned surgery. Now, what you often find with inpatient survey results is that patients that have elective surgery score higher than patients that have emergency admissions or admissions into medicine. I don't say that by way of an excuse, but it is actually part of the rationale that does explain some of the survey findings. We'd made some really good progress on the inpatient survey with the previous year's findings being much improved, and it was very disappointing to get this year's results, which aren't where we want them. But hopefully I'm going to show and share with you some detail which will tell you that we have been doing additional assurance checks ourselves and audits, that particularly around some of the questions where we scored the poorest. Next slide, please, Jackie. So 1,250 patients were sent the survey, of which we had 462 responses. That's about 39%. That is low compared with national averages, and we usually have a response rate of between 35 and 40%. And at the bottom point, so 57% of responses were from patients who were general medicine or elderly medicine, and the rest of those responses would have been from patients having emergency surgery, so not planned surgery. Next slide, please. When we look at the banding of results, and I do apologise because this makes dim reading really. So we were better than trust. So you banded into 4 bits really, several bits, sorry. Whether you're average, better than some trust, worse. And actually we were average for 25 of the questions, much worse on 10, worse for 9, a little bit worse. So sorry, somewhat worse 10. Worse for 9 and much worse for 1 question, with no questions being better. And I don't think that represents the care that we give. I think we deserve to have better survey results, and I'm committed to improving that. Next slide, please. So this is a sort of a bar graph. So what this shows, now you've got to remember that there's very small numbers involved here. So our overall result was 7.9. So that's an average of all of the results. Right up to the right-hand corner, which will include some specialist centres that might not have been impacted by COVID or that don't have A&E departments. Right down to the bottom end, and you can see the range starts at just over 7. Now, within that basket of those trusts there, Mid York scored a 7.8. I think Airedale scored 8.1. Airedale usually scores really quite well on their inpatient survey, but there was a definite trend in Northwest hospitals and Yorkshire hospitals of a downturn in results. And I do believe that was due to the pressures we were experiencing at that time, and we were being compared with some hospitals that weren't having COVID pressures and admissions at all at that time. Next slide, please. So that's just a slide. You've got these slides in your pack. So there were some good news. So as well as getting the scores to the questions, there's some free text comments. So there's a couple of nice comments there. Next slide, please. So the survey finding details, there were a few areas that we've really focused on, and I've been doing a lot of work over the last year to 18 months on that. So that's pain, food, communication and discharge planning. If we go to the next slide, please. So what we've tried to show here is what we've been learning about these things, and I'm going to take you through a set of slides for each of those 4 points, and then our own audit data. Now, it does refer to internal audit. That doesn't mean internal audit that we review at audit committee. It means the audits that we do internally on the wards with the patients, and we use a tool called Iqv, and we've continued to do that throughout the COVID-19 pandemic because it's a quick and easy way just to check on the basics of patient care, but also on several safety issues. So those of you who've seen some of the board reports will see that we use this tool also to look at things like safe staffing and whether some of the basic checks around crash trolleys and things are done as well. So with the learning from pain, we've done a lot of work around pain assessment. We've been working with the acute pain team, and we have a pain steering group. And we're also starting to look at education for staff around pain. There is work to be done around care planning across the board, but in particular for pain. And this was work that was actually planned back in, I think it was actually planned to have a joint care planning session with Calderdale, who we actually share our EPR with, to look at how we can make it more user-friendly for nurses. Was planned for May 2020, but then the pandemic happened, and in a blink of an eye, we've lost 2 years. So there is work to be done around the care plans. But if you go on to the next slide, please, Jackie, you will see this is from our Iqv audits, and you can see when we've done our own internal audits, the results are quite favourable, with all of the, well, over 91% of patients saying that they're always being helped to control the pain, which I think is a positive thing. Next slide, please. So this again just talks about some of more of the improvements that we've taken with pain, how we are looking at communicating differently with patients, how we're making sure that we just don't wait. You know, doctors have a habit and nurses have a habit of allowing doctors to do it, of prescribing drugs at sort of 6 midnight. Well, if you've not got your pain at midnight, but you've got your pain at 2 o'clock in the morning, you're going to want some pain medication at 2 o'clock in the morning. So we need to make sure that we're not reliant on that, and that we are asking people regularly if they're in pain and if they need that. But then going back and checking that that pain medication has worked. And we also need to be aware of patients that might not have capacity or are unable to communicate, because just because somebody can't tell you that they're in pain doesn't mean that they're not in pain. So we continue to use the audit tool, and we're also going to audit how we refer people to the pain team as well. Next slide, please. So food is interesting, and our food provider is one that's used at several hospitals around, and Mark Holloway and Estates has been looking into how other organisations score on their food and how they manage their food. What we do know is that during the COVID pandemic, at the start of the pandemic, we had a limited menu for food. So we didn't have the full range of food available. In addition to that, and we learned this from the amount of food that was being dropped off for patients, a lot of our patients relied on food being brought in from home or home cooked food. And we actually stopped that from happening, and we weren't allowing people to bring hot food into the hospital. So a lot of patients were fully reliant on the hospital meals that may not have been to their taste. Because I presume it's the difference between having your mum's Sunday dinner. Actually, you wouldn't want my mum's Sunday dinner. My Sunday dinner, or one that you buy in a plastic thing that you heat in the microwave. But we are really sort of homing in on food, and I'm going to talk a bit about some of the stuff that we've done around that. Next slide, please. So we've done a lot around finger food, because we know that, I mean, you know, if you're ill yourself, you don't really want to sit down and eat Sunday dinner. You probably want to snack on an egg sandwich, or, you know, pick at something. So we've done a lot of work with the dietitians, particularly for people with cognitive impairments, around bits of finger foods that people can pick at, can feel, and can eat. We've also done more work about specific diet requirements and how people can order a more variety of foods. And we do have specialist a diet chef available 7 days a week. One of the other things that people often report about hospital food is that it's quite bland. And you have to recognise that when the hospital food is is almost prescribed to quite exacting standards. Now, other people will like the salt on their food, and of course we don't put lots of salt in hospital food because it's bad for you, but we do know it enhances the flavour. So that is, you know, another of the reasons why people don't always like hospital food. We're also doing the place light, and we'll start that, looking at doing some spot checks, talking to patients when they're eating the lunch or the dinner, and we're doing a lot of work with the nutritional steering group, which actually is about to restart as our head dietitian, which some of you will know, Jackie Loach, is retiring, and the lead AHP, Jamie Kingsley, is going to start leading that piece of work going forwards. Next slide, please. We've actually purchased something called an iWave for A&E. This means that we can now give people, it's not quite a microwave, it's an iWave. I'm not sure what the difference is, but patients can have a hot meal in A&E. That's particularly important because we know the waits in A&E are longer than they have been in the past. That's a national position. And we've appointed some operational support workers in A&E whose job is to walk around the A&E department, checking that people have had food or drink if they can eat and drink, and providing those to people. We've also looked at our carers passport to make sure that if we do have patients with additional needs, that we know what their needs are, because there's nothing worse than being given a food that you don't like. So people have the favourites and people have the comfort foods when they're unwell. We've got protected meal times in place. One of the other major factors, I think, has been because we fully restricted visiting at the start, we didn't allow relatives the opportunity to come in and sit with patients and help them at meal times. Because we often found if somebody had a visit, we find that when somebody's got a visitor with them, they are more likely to eat. And indeed, only today, after a suggestion from Madge, one of our consultants in elderly care, we were talking about if an elderly person has their elderly relative visiting with them at a meal time, actually, should we provide them both with a meal so they can sit down in a more of a normal environment and share a meal together and encourage the person that's in hospital to eat. We've also done a lot of work around red trays, which automatically identify if somebody needs assistance, and work with OTs to make sure that if people struggle to hold a knife and fork, there's special cutlery that can be used. And we're doing lots of education around this as well. Next slide, please. So communication. So one of the big things, and again, it was Dr. Brown in elderly care. What we found when we've moved to EPR is that patients feel sometimes that you're not speaking to them or not talking to them because you're having to type things into the EPR. And Dr. Brown's idea was to put a big sign on the back of the EPR that says, "Don't worry, we're still listening to you. We're just busily typing around." So we do encourage all staff to say to patients, you know, I am listening, but I do have to record in real time on the machine, so it might look like I'm distracted. We also need to make sure that we're looking actually to make sure that we, sorry, I've lost my thread, that we, sorry, I've completely lost my thread now. So we need to make sure that we're looking at sustained change, but using a methodology to do so. So we talked about QI right at the start of this. Well, actually, quality improvement is a methodology that can be applied to anything. So we need to make sure, whilst we're looking at enhancing communication, that when we put any pilots or interventions in place, we're actually asking the patients afterwards whether or not it's making a difference. So pre-pandemic, and this made a major difference to the inpatient survey a couple of years ago, we actually had a junior doctor going round after the ward round saying, "Do you understand everything that the doctor said? Is there anything you'd like me to go through with you again?" And it was amazing how many people then go, "Yeah, actually, I didn't understand what you said when X, Y, and Z." And that made a real difference. So we want to really sort of start that work again. Next slide, please. And again, here's some assurance, and these are some of the Iqv audits that we've done. And you can see, 90% isn't 100%, but 90%, over 90% for both nurse, when asked about nurses or doctors, patients reported that they did not feel that patients, were talking about them without them being here. So that's a positive finding there. Next slide, please. So again, these are some of the campaigns that we're doing that Patient Experience are leading on. And we've got our Patient Experience, an internal sort of conference coming up in a couple of weeks, where a lot more of this work will be talked about. Some of the CVUs had some badges made with Ask Me About Your Care. There was the Good Night Sleep Tight campaign, which was around having a hot milky drink before bedtime and asking a patient if they're okay and any worries. All of these things, we just need to get back into that sense of normality. And it's really hard because it's not yet normal in the hospital, but we're trying our best to get there. Of course, staffing levels will have had an impact on this as well. So although we have maintained safe staffing levels throughout the pandemic, it is not our optimum staffing levels. So where staff may have had time to chat for a little bit longer or take that extra minute with Sunday, staff haven't been able to afford that luxury, and that's really unfortunate. But as we're seeing people getting back to work now because they've not got COVID, as we're seeing our recruitment increasing, we believe that we will start to see an impact on that. Next slide, please. Discharge planning was really, really disappointing because this is something that we do really well on at times, but we know from the inpatient survey, and we also know from the complaints that we've received over the last 18 months that something has been missing on discharge planning. Now, one of the major factors in that, I truly believe, again, goes back to stopping visitors. So you will know if you've been in hospital or you've visited somebody in hospital, every day when you come in, there's that interaction and you're getting ready to go home and you know what's happening and your family knows what's happening. And I think some of that has been lost. I do apologise, I'm trying to be as quick as I can. So there's a lot of work around improvement. We've got a new lead in the MAID team who's doing an excellent job. We're looking at discharge information as well. I won't go through every point. I'm sure people can pick that up. Sorry, next slide, please, Jackie. There's just some assurance on discharge planning. So again, have hospital staff told you who to contact if you're worried about your condition. So that's about showing at 94.5% on the donut. So again, when we've asked patients that question, they're reporting positively. But I do think there was a moment in time in that first 6 months of the pandemic when it was very, very difficult. Next slide, please. I've covered that slide. Next slide, please. So here's some of our best scoring questions. Always best to try and finish on a high. So length of time waiting to come into hospital. Were you prevented from sleeping at night because of hospital lighting? Again, that's something that we've drummed into staff around that good night sleep type routine. Will you be able to discuss your treatment? Again, when asked doctors' questions, did you get the answers you could understand? Again, a good score on that. And did hospital staff tell you who to contact if you were worried after you left hospital? So again, 7.7. Next slide, please. That's some of our positive comments. Next slide, please. I think I've talked about most of this as I've gone on. We were hugely disappointed with the results. Our own data, again, our own audits that we do continuously do show a different picture. But I do believe this was reflective of the time and at the peak of that second wave for us as well. I'll leave it there and thank you. Any questions?
Thanks very much indeed, Kevin. Thank you. Governors, I am conscious we're running over a little, but we've got the closed session as well. Of course, we'll try and claw some time back. I did feel that deserved some attention and time, and I'm grateful to Karen for running us through it. So we've heard what we've heard. We've seen the strong areas and the weaker areas. and with some thoughts there about the way in which we're going to try and deal with those things. Did anything arise that any governors would wish to just put down for information, interest, or indeed questions? So, Adrian, would you like to come in, please?
Just one thing. I don't know what the sample size is for the assurance. I know what 5% of 454 is. It's 23 patients, but what's the actual sample size for our own assurance?
Sorry, I haven't got the exact figures. I can provide them with pleasure after the meeting. I know it is large numbers though, because we run the surveys twice a day on all of the inpatient wards, and the majority of the wards fill them in twice a day as well. So it is hundreds rather than small numbers.
It's just that 0.6% doesn't make a number for me if I don't know how big the sample size is.
No, I completely understand that.
I should say though, I think your action plans are fantastic. I think there's a lot of insight, of course, and experience in there. I've waited while mourning for my pain relief 20 years ago, and that's, you know, having that type of insight really, really important. And I like the follow-up idea for the communications, particularly for the elderly. I've spent a lot of time re-explaining to my elderly parents and in-laws what's been said. So I really like that idea as well. Okay, thank you.
Thank you, Adrian. Yeah, well said, and an entirely appropriate question. What sort of volume of responses are we looking at for those assurance questions? So, Karen, thank you. I hear that you'll provide that, and we can share that with governors. So, at least a feel for the numbers we're talking about there. Thank you. Yeah. And were there any other points arose from that? No. It's pretty detailed. I want to say, of course, I know we're dealing with a council meeting at which there's a lot of matters to deal with. So again, the corporate governance team will welcome any additional questions that might have arisen, or if you're reflecting on it afterwards and you think, what is it they're doing about that bit, or what was the issue there? We'll be happy to try and deal with those. Yeah. Okay. Thank you very much, Karen. Thank you. We're asked to note that. Okay, we've got just a few items to finish with now, which are fairly transactional in nature. There's no way I'm going to shut down any debate on any of them, but of course some of them you may feel that you've had the chance to see the paper and are happy to approve the proposals. So shall we go to item 10 then, which is our annual evaluation and skills, knowledge and development audit. And with this paper we are being asked to confirm our support for the development of an action plan based upon the outcomes from the annual evaluation and the skills, knowledge and development audit. And indeed, Laura, you and I had a chance to talk about this before, didn't we? And we said that we'd welcome some governor involvement, hopefully, in that process, the production of the action plan. Laura, shall I pass to you and see if there's anything you wish to bring to people's attention, please?
Thanks, Max. Yeah, I won't run through the whole report, obviously in the interest of saving time. I think the key points to raise are the actions from last year, the evaluation that we undertook. We've attached the progress on that Appendix 1, so all actions have either been completed or they're ongoing. So some of the things that we did in response to last year's evaluation was to review and update the Governor Induction programme, and I think the new version of that was well received by our new governors who undertook that late last year. We also arranged some training for our governors through Govern Well, which is part of NHS providers. So they've delivered 2 sessions around finance and business skills and member engagement so far. There's also a further session around accountability, which is due to take place in June. This year's feedback is pleasing. We've had an improvement from last year, and we've only got 3 areas which are rated as amber. So they're around consulting governors on the long-term strategy, effectiveness of the council in representing the interests of members and the local population, and the way that the council's decisions are communicated externally. Again, these areas have improved compared to last year, but clearly there's still some more work to do in those areas. In terms of the skills audit, there's two areas which are most popular around requiring further discussion, and that's around quality, safety and patient experience, and also performance. Again, accountability was identified as an area requiring development, but that session with Governwell will take place in June, which I hope will support that. Again, governors shared with us their areas of knowledge and expertise, and they're very wide ranging, so we can look at how we can use those in delivering the council's business going forwards. As you said, the next steps are to develop an action plan, and we'd like to invite at least 2 governors to support us to develop that, and we'll present it at the next meeting for agreement. That's all I wanted to say. Thank you.
That's great. No, thank you, Laura. Yeah. So just to pause for a moment to see whether anybody had anything they wish to raise regarding that audit. And the proposal to actually, let's get an action plan going, and let's make sure it's an action plan that governors themselves are contributing to the production of. That's the proposal. Can I assume that that is carried? No objections and no further detail required. And of course, the action plan will allow for further debate on some of those areas that are weaker perhaps than others. So yeah, but as Dermot rightly points out, there are indeed some improvements there as well. So yeah, if everybody's happy with that, that's great. Thanks, everybody. And moving on to item 11, please. That is the annual members meeting and the AGM. And let's sort out a planning group for our AGM intended to take place on the 23rd of September. So again, Laura, should I pass to you, please, just to see whether there's anything you'd wish to raise? You are Jackie, of course.
Yeah, I think Jackie's going to cover this one. Sorry, Jackie.
I'll cover this one. I think you've basically said it, Max, really. We do the AGM, AMM annually. We've delivered it in line with the Constitution. We've historically combined the 2 meetings. And so we're proposing that we do the same again. What we want to do is establish a governor working group to help set the programme, and also to look at, kind of feedback around viewing and so on, and to determine if, kind of we do want to deliver it face to face. I know people have spoken about that before, but I think probably be best if it's backed up by either some figures or some, kind of concentrated thought and so on. So it'd be great if governors could get in touch and join the planning group. If you could do this with Sheridan by Friday, 6th of May, that would be great. And then we'll bring the proposal back to the next meeting.
Thanks very much. That's perfect. Yeah. Thank you, Jackie. And so again, everybody content that as is proper, there'll be good governor engagement and influence and steer on the nature of the AGM and annual members meeting. And we're hoping that if any governor is interested in joining that planning group, as Jackie said, 6th of May, before the 6th of May to Sheridan, and those expressions of interest would be welcome. Happy with that? Yeah, I think we've got that. That's great. Thank you, everybody. I'm not meaning to miss out on things. And Karen, there was a question from Sugra about whether there's a cut-off, so our non-exec director, of course, whether there's a cut-off time for patients being woken up to sleep out on other wards. Is there a cut-off time for discharges at night, especially if people live alone? Karen, do you have a moment to cover that particular issue about cut-off times?
I think Karen had to leave, Max.
As Karen had to leave, right? Okay. Oh yeah, sorry. I've got it's right underneath, isn't it? Need to go to another meeting. Okay. So we will pick up on those points with you personally, and if there's something to share with governors, we'll make sure that happens. So thank you for your points. Okay. The next item, item 12, is the report on the chair appraisal process. Now, Julie was to present that, but I know Julie did have a 5 o'clock, but I know that she's spoken with Laura about what the matters to perhaps raise with governors. The point of the paper is to assure the council regarding proper process being undertaken. But given that it's about the appraisal process for the chair, it's right and proper that I should defer the chair for this to David, and that I step out of this meeting. Just to obviously offer the chance for any governor who might have wanted to raise something about that process. So in that case, I'm going to leave the meeting for a moment. I'm going to sit here and hope that you invite me back. And if you do, I'll be straight back in and we'll get on with the rest of the matters. So David, if I may pass the chair to you, please. But I know Laura is ready to, I think, just brief governors. So,
okay.
Jackie, when I leave this meeting, it won't close it down for everybody, will it?
I'm not certain, Max. I think we've had this before, so I will try and bring you back in.
I'll press leave for myself in the hope that if it does stop it for everybody, don't all go, will you? Rejoin, won't you? To find the link. Okay, I'll leave now then. And
Max, you can just come back in through the calendar.
Oh yes, no, I know how to come back in myself. I was concerned that by leaving, was I going to close it down for everybody else?
No,
It won't do.
That shouldn't happen, should it? Yeah. Okay. Thanks everybody, and I'll hope to hear from you in a moment.
Right then, Laura, it's over to you then, I think.
Thanks, David. I'll be really brief. Julie's just given me sort of 3 key points that she wanted to put across. So, Max's appraisal was actually undertaken by Selina Ola last year, who was the senior independent director at the time. Obviously, she had a handover with Julie when Selina left, and Julie took over as senior independent director. Julie's confirmed that the process was followed, and I think that's set out within the paper. Views were sought from the chief executive, non-exec directors, stakeholders and governors, which fed into the process. And the outcome was that the chairman's performance continues to be effective, and he shows commitment to the role. So yeah, governors are asked to confirm if they're assured that the correct process has been followed.
Right, thanks, Laura. So I guess the first thing is, any questions on the paper and what Laura's just said? Nope. So unless anybody shouts out in the next few seconds, we'll take it that the appraisal process has been approved.
Thank you. I'll send Max a text soon as it can come back in.
Okay then, thank you.
Thank you.
All approved, Max. So back over to you. You're muted, Max. Max, you're muted.
Hi, everybody. Thank you very much. Thank goodness I'm invited back in. There you go. And I just did want to make sure colleagues do know that David and I support different football teams. So, and it seems to be working well.
Yeah.
But you did knock us out of the FA Cup, and you never know, the Champions League's a possibility.
Well, yeah.
Okay, so hopefully you were assured, and I'm sure I will hear, as is proper, from Laura later if there was any comments or thoughts. So thanks. And we are continuing recording this meeting, and I'm back in the chair. Thank you, David, for picking that matter up. Item 13 is to note the Governor's Nominations and Remuneration Committee report. Wendy, is there anything you would wish to bring Governor's attention to in particular, please?
Yes, I wasn't at the meeting, so I think David's going to do this one.
Thank you. Thanks, Wendy.
Well, I'll take it. The paper's been read. There's the transactional sort of stuff about the processes. I think the most interesting thing was the discussion we had on the time commitment of NEDs, which we found, well, the research was appropriate and within the allocated time commitment of 4 days per month. I hope that the NEDs agree with that. But yeah, that's the paper, and it's just to note. So I suppose unless there's any questions.
Thank you, David. And David may suggest you're selling the NRC slightly short, in that a really great suggestion came out of the NRC about measuring the impact that non-exec directors perhaps have the trust. And whilst we're not suggesting that that's individual impact, just an idea of articulating the sorts of impact we're having. So I thought that was very powerful and a very well made point by NRC colleagues. So thank you for that. Yeah. But as David rightly and succinctly says, it's about noting the paper, but obviously an opportunity for anybody to ask anything should they wish. And if there's nothing and we're content to note, I'll happily do that. Thank you, everybody, for that. And I'll move, Laura, to yourself, please, for paper 14, which is to approve the chair and NED appraisal processes, which again, helpfully, I think have had some sight beforehand, haven't they, by certain members?
That's right, yes, thanks, Max. So they were reviewed by the Governors NRC in March. So we review these appraisal processes on an annual basis, obviously before the appraisals take place. In relation to the chair process, we're proposing some amendments to ensure alignment with the provider chair competency framework, which is a national framework. And there's a sort of national expectation that our processes align with that. So we've made some slight amendments to make sure, you know, that we're addressing that requirement. In relation to the NED process, we're proposing some minor amendments. So that's to reinstate the NED peer review process, which we haven't done for the last couple of years through COVID, and to clarify that NEDs may have more than 2 personal objectives if required. And finally, to include a section within the appraisal form to record the impact that the NED has had, as you just mentioned, following a suggestion from the Governors NRC. The Council is just asked to approve those processes which are attached with the paper. Thank you.
Thank you very much, Laura. So again, just taking a pause in case anybody did have something they wanted to raise about that, but we've been asked to approve those appraisal processes, which have had good sight by NRC, as Laura says. Comfortable? Happy to approve? No further comment? Yeah, thank you, everybody. That's great. And then similarly, we have our own Council of Governors Terms of Reference review. So again, Laura, anything we ought to think about for this before being invited to approve?
I think Jackie's covering this one for us. Thanks.
Oh, okay, thank you.
Thanks, Laura. Yes, I'll cover this one and I'll cover the next one as well, Max, if that's okay.
That's fine, Jackie, of
Both
course.
pretty straightforward. Council of Governors Terms of Reference review. Governors review these every year, annually, and so there are no changes proposed from last year. And so the Terms of Reference are attached, so they just require the Council to approve them if they're okay with the content.
Thanks very much, Jackie. And again, hopefully, if colleagues have had the chance to have a look at those, were there any comments, thoughts, or anything that anybody wanted to raise? Or may I take it that we are content as a council to approve those terms of reference? It would appear the case without further comment. So thank you, everybody. Very much appreciated. Please don't feel rushed if there's anything anybody wishes to say, but I'm pleased that you can see these as matters that have been managed properly. So thank you. And may I move to item 16 then, which is the our own standing orders review. There's some minor amendments there, I think, Jackie, isn't there, that shall I ask to you again to bring to our attention?
Yes, please. I mean, with this one's slightly different in terms of the terms of reference. There are some minor changes on the cover page. There's an amendment to paragraph references within the Constitution and an addition of a hyperlink to the Foundation Trust Conflict of Interest policy on page 10, section 6.1. So they are minor changes. The only thing about the standing orders, though, is that it is the one document within the Council of Governors arsenal of responsibilities where it needs actually 2/3 of the council to approve any changes. Now, at present, there are 13 governors present. We actually require 14 to make a formal approval. Now, I'm hoping that, you know, kind of the majority of governors here are okay with this and would, you know, kind of approve it. And then we go to Anne Forster outside of the meeting and just ask for her approval there. Otherwise, I think the other option would be to bring them back to the next Council of Governors meeting. So it is basically the recommendation changes slightly. So this Council of Governors is asked to review and approve the proposed amendments subject to the approval also of Anne Forster, missing governor.
Thank you very much, Jackie. Thanks. In order to have the proper numbers for quorum.
Yeah.
Yes. Yeah. And again, just pause and ask whether there are any comments, thoughts, concerns, or issues. And if there are not, I will assume approval in that case. And as Jackie says, we'll just check with governors who weren't present as to whether they have any issues they wish to raise. Yeah. Okay. but we will take that as approved pending checking with other governors who are not present. Jackie, yeah. Thank you very much indeed. Thank you. And at item 17, we have again very minor amendments to our annual work plan review. So Laura, is this back with yourself?
It is, thanks Max, but I'll just take the paper as read if that's okay. I think the changes are outlined clearly within the paper, so just happy to take any questions on that one.
Yeah. Can I just check whether were any governors involved in the review of that work plan, Laura, or has this been done by the corporate governors team and proposed to council now?
Yeah, we've just reviewed it within the team. Yeah.
Yeah. Okay. So again, in the spirit of a lot of business to deal with, if anybody has any comments or issues, the corporate governance team will of course welcome those and answer them. But otherwise, I'm saying pending any reflections after the meeting, are we content to approve that annual work plan, please? I don't think there's any major changes that we would normally have, Laura, is there? And it's it's subject.
Just reflect the current position and changes in committees, etc. But yeah, we can make changes at any point throughout the year, so it's not set in stone if there are any changes that come up.
Yeah, that's fantastic. Right, thanks very much. And again, I'm assuming in the absence of any hands raised or people wishing to comment, we're taking that for approval as well. Right, thank you very much indeed, everybody. We have that. That's great. I realise we're going to go into a closed meeting. I'll make sure there's a 5-minute break for people just to stretch their legs, and we'll hopefully deal with those matters fairly succinctly with that. Okay. At item 18, of course, we have the Academy reports and the Audit Committee reports, and I was delighted to hear, of course, that some governors were able to refer to them as we talked about various issues. Can I express my sincere thanks to all governors and directors who've been able to stay with us? And do note, I know we've run over 20 minutes, but it's only, is it not, only because actually we tried to focus in on what you guys wanted us to talk about. You know, we listened to the points you raised right at the beginning of the meeting and sought as non-execs and then with executive support to give you as much detail as we possibly could. And of course, we've picked up on a couple of actions that further information that will be required. So there will be some more short briefings just coming out related to the issues raised by governors. So thank you for that. Is there any other business that needs to be discussed today? I always ask it right at the start of the meeting, don't I? And I've obviously not done that. So don't give me a list of 10, will you? Having said that, if there is, we will deal with them. I'm chairman. Okay, that's great. So if there's no other business, that's absolutely fine. Thank you. Does anybody wish to raise any particular thoughts at item 20 of a review of the meeting? Obviously happy to hear any thoughts either now or subsequently or later. So if there's anything I need to know, then happy to hear that. I'll just check in chat to see what, I realise some people are having to go now, so that's fine. I understand that. Yeah. Okay. Well, before we lose everybody, can I just take a moment to reflect on, now I think, and I'm going to look at Jackie and Laura for support here, but is this the last Council of Governors meeting for a couple of our esteemed, respected and experienced colleagues in particular? I think Wendy, having served 6 years as a public governor for Keighley, and indeed Hardev, having served 9 years as a patient governor. I hope I've got those numbers right. It may be as well that Stella, I appreciate Stella's not here, but she's given 6 years of her service to us, has she not? And Jackie, I'm looking for you to correct me if I'm getting anything wrong here. So I think that's right. I do know we've got elections coming up as well, which does affect some of our colleagues here. And obviously, as chair, I hope to see them back here. Having said that, though, can we endorse, and I'm sure you'll join me, please, in sincerely thanking Wendy, Hardev and Stella for everything they've given us. And my goodness, seriously, the experience with the wheel miss there is a shame. Having said that, of course, it's an awful long time to give. So Wendy for 6 years, Stella for 6 years, Hardev for 9 years. It's been fantastic. would you wish to, Wendy or Hardev, would you wish to say anything to Governor colleagues as we close this meeting? Hardev, please. Yeah.
Yeah, no, I was just going to say I can't believe it's been 9 years. It seems to have gone in a, yeah. Yeah, I mean, I'd like to thank obviously Sheridan and Jackie for their support over the years. They've been kind of long-standing colleagues. Obviously, personnel have changed in that time. And obviously, Max, as the chair, you've been fantastic as well. So I'm going to miss it, I have to say. It's been a real pleasure, and my governor colleagues as well. So it's been immense support. It's been very collegiate. It's a lovely group of people. You know, obviously, governors have changed immensely over this period of time. But yeah, it's been a real pleasure, and I will miss the time. So I'm hoping I can try and, you know, get some volunteering in or something to keep my link with the hospital anyway. And I will pop in, Jackie, to, you know, thank you and what have you. Hopefully when we next meet in June. So yeah, thank you.
Thank you, Hannah. Seriously, thank you for everything you've done. Thanks. Wendy, would you like to say a word to colleagues?
Yeah, I mean, I echo my thanks to Jackie and Sheridan and you, Max, for being so supportive over the years. I've really enjoyed it, and I'm still enjoying it. But I don't want to do another 3 years and then feel that, you know, I'm past my sell-by date. So I do think we need some renewal. I hope we can keep in contact. You know, I've got a few other irons in the fire which might bring us in contact. And I hope that we'll be able to go out for a meal maybe towards the end of June or July to share a meal for everybody. Welcome to come, and that would be nice. Nice goodbye.
Yeah. What a great idea, Wendy. An open invite, casual.
Yeah.
If you can make it, great. If not, we understand. So what a lovely idea. Yeah. Fabulous. Wendy, also to you, and recognising your role as lead governor too, of course. You know, thank you so much for everything you've done for us here. And hey, isn't it nice that you're both leaving as governors, whilst at least we're good according to the Care Quality Commission? And let's be right, that's an accurate reflection of the direction we've been taking. So let's hope we can build on that. But you know, sincere thank you to both of you, and sincere thanks, of course, as well to Stella, who we love dearly and is in good form, I believe. Health is good. Okay. Thanks, everybody. That's terrific. So we meet again, of course, as governors on the 21st of July. And as I always say at the end here, we have a council business to deal with the business that we have to see to. And of course, a lot of that's decision making, etc. But we remain available to you through the team, through myself. We will always answer questions that are raised appropriately with us. So we'll do that.